This topic is complications of fractures. Acute complications. Venous thromboembolism, or VTE, due to the immobility and the muscles that normally help pump venous blood are inactive. There is an increased risk for VTE with femur and hip fractures because those bones are very vascular. That's why it's important to do any exercises that have been allowed for the client, like flexing of the foot or range of motion on the leg that is not injured. A lot of times, these clients will also be on anticoagulant therapy. Infection. This is a major concern, which can cause delays in healing for the client. The client is more at risk for infection if they have had an open fracture where the skin has been penetrated, allowing outside organisms into the body. Either bone or soft tissue can be infected. And more problems can occur if an area that has had hardware implanted becomes infected. Now the client may have to have additional surgeries, and oftentimes more hardware cannot be implanted until the original infection is gone. All of this delaying healing. Organ damage, which may be caused by the fracture fragments or trauma force. Like with a pelvic fracture, think of all the internal organs that can be affected in that area: the bladder, urethra, colon, or how about with a rib fracture, puncturing a lung? Cosmetic deformity. If the client had surgery and an incision, external fixators, or if the fracture is not healing properly. Increased bleeding or hemorrhage. If there is any damage to the vessels in the area of the injury. Cerebrospinal fluid leak. You may see CSF leak from the nose or the ears with a skull fracture. This indicates that there is a tear in the dura. If there is a tear in the dura, the client could develop meningitis. The dura is a protective layer of the brain. If there is a tear in it, bacteria can enter, and then the client can develop meningitis. Compartment syndrome. This is a limb-threatening condition caused by decreased compartment size, the fascial space, the area between the fascia and the other organs and tissues below it, including muscle and nerve fibers. There's only so much space in there, and your skin can only stretch so much. This can also be caused by an external pressure, like from casts or restrictive dressings. Increased swelling in this limited space causes compression of arteries and nerves, eventually leading to ischemia and impaired nerve function. You can see in this image the swelling and then the cross-section of the arm. The arteries are still patent as of now, but the veins have already been compressed due to the edema. This is why it is so important to perform those neurovascular assessments for these clients. This pressure has to be released. The cast or dressing has to be removed. Or the client will be taken to the operating room for a fasciotomy, in which the skin and fascia are cut to release the pressure. For more detailed information about this complication, I encourage you to watch the video on compartment syndrome. Volkmann contracture. This is associated with distal humerus fractures and affects the hand, wrist, and fingers, as seen here in the image. It occurs as a result of ischemia from compartment syndrome, the arterial blood not reaching the hand and lower arm. No blood flow means no oxygen, leading to ischemia. This is a medical emergency because permanent damage may happen if it is left untreated. This may be caused by a cast or splint, and that will need to be removed immediately. This may also be caused by a trauma or injury, like a crushing injury. In that case, a fasciotomy may have to be performed. Fat embolism. This is a life-threatening complication of a bone fracture. It's typically seen with the pelvis and long bone fractures. You can see what happens here in the image. Fat globules from the marrow of the broken bone will enter the vasculature and travel via the bloodstream. They will obstruct small vessels, normally in the brain or lungs, causing impaired circulation and ischemia. This can lead to acute respiratory distress if the fat emboli collects in the lungs, and neurological impairment if the fat emboli collects in the brain. The client will have dyspnea, confusion, and petechia on the neck, chest, and axilla from occlusion of microvascular vessels. That petechia is an important finding because it differentiates a fat embolism from a pulmonary embolism. Treatment of fat embolism depends upon the symptoms the client is experiencing. It may include oxygen, IV fluids, and bed rest. Chronic complications: avascular necrosis, disruption of blood supply to the bone. No blood supply means no oxygen supply, which results in bone cell death. Delayed union. The bone is slow to heal or does not heal at all. There's non-union. This can happen due to underlying medical conditions that stall healing, like diabetes, malnutrition, peripheral vascular disease, or infection. Complex regional pain syndrome. This is severe, persistent pain, and it's due to damage to the nerves in the area of the injury. It is often associated with hand and foot injuries. Nursing interventions. Our goal is to restore function and prevent complication. We want to maintain reduction and immobilization of a fracture to promote bone and soft tissue healing. This will include positioning and monitoring any areas of skin breakdown with any immobilization devices. Reducing edema. We know edema can cause damage to the surrounding structures, as seen with compartment syndrome. We can remember RICE, R for rest, I for ice, with that initial trauma to promote vasoconstriction and help decrease swelling. C for compression. Compression bandages offer support and can help with decreasing the edema. And E, elevation, elevating that extremity above the level of the heart. These steps are really important with soft tissue injuries. We will monitor neurovascular status, monitoring for compartment syndrome, or any vascular or perfusion interruption, and note and report any changes. Post-surgical fixation, we will monitor drainage, monitoring for infection, and we will administer analgesics to allow the client to rest and heal. We need to monitor their neurological status. Are they oriented? Monitoring for fat emboli or venous thromboembolism. And increase daily fluid intake to flush toxins and promote blood flow, bringing that oxygen to the area of injury and preventing deep vein thrombosis. And we will encourage gradual resumption of daily activities. We will work together with the physical therapist to make sure the client is performing the correct exercises and to know how much the client can or cannot do.